Hello everyone. Here we are discussing about the role of intervention radiology in treatment of lower gastrointestinal bleed. And I am Dr. Eben Jose and I am doing training in intervention radiology. So, small introduction. Lower GI bleed refers to bleed originating from the GI tract distal to the ligament of Treats, primarily jejunum, ileum, colon, rectum, anus, and predominantly it is the large bowel. So, the territory is supplied by SMA and IMA, and also the internal iliac artery can also give branches like middle and inferior rectal artery that can also cause bleeding of the rectum. So here in this image you can see this is the SMA and this is the inferior pancreatoduodenal artery. This is the right middle colic artery. This is the right colic artery. This is the ileocolic artery. And here you can see this is the IMA, and this is the left colic artery, multiple small sigmoidal arteries, and the superior rectal artery. So here you can see there is an anastomosis between the SMA and the IMA branches. That is the right colic, middle colic, and the left colic. Here there is a connection, and this will be just at the colon, margin of the colon. This is known as the marginal artery of Drummond. When we talk about collaterals, let's talk about the other collateral pathways also. This is the celiac artery and this is the SMA. Between both, connection between both will be the arc of Buehler. That is a direct connection between the celiac artery and the SMA main trunk. Another one can be the GDA and the pancreatoduodenal artery. Another connection between the SMA and the IMA, one is the marginal artery of Drummond, which we had described in the previous slide. The other one can be the arc of Riolan, that is between the SMA and the IMA. This image is also depicting the same pathways. One extra one they have shown here is IMA will give a superior rectal branch, and that will have anastomosis with the middle and the inferior rectal branch of the internal iliac artery. Now, what are the causes? Causes can be diverticular disease, that is the most common cause. Other causes can be colorectal carcinoma, angiodysplasia, inflammatory bowel disease, hemorrhoids, vascular malformations, etc. Now, what is the role of intervention radiology? So, we provide a minimally invasive approach. There can be targeted treatment where we'll go to precise location of the bleed and stop the bleed over there by embolization. It has reduced risk in the form of lower morbidity and mortality compared to mainstream surgery, and you can get an immediate result because you can stop the bleeding quickly, and in fact it has a lesser recovery time also. Now, when do we do this? In case of persistent or recurrent bleeding where the endoscopy has failed to locate it or control the bleed, hemodynamic instability where the patient is having ongoing blood loss and the vitals are very unstable, failed conservative management where endoscopic hemostasis was done before but however the patient has bled again, and the patients who are not suitable for surgery where there is a high surgical risk due to comorbs and other high risk factors. The main workup we need is definitely clinical assessment, then colonoscopy, flexible sigmoidoscopy if needed, and in imaging, CT angio is very good. It will tell us where the exact bleed is from the which artery. Another thing that can be done is radionucleotide scintigraphy. This is nowadays rarely done, so this is more helpful in patients with intermittent or a slow bleed. And then the gold standard is DSA, that is angiography. Here we'll have a direct visualization of the blood vessel, and we can go ahead with embolization also. So in intervention radiology, first we do an angiography. So the access is usually taken from a femoral or a radial artery, and a catheter is introduced, and we'll find the exact site of bleeding. And once we have found the site of bleeding, we'll go ahead with embolization. And the embolization materials we have will be coils, gelatin sponge, PVA, and glue. Details about these is discussed in the previous video of upper GI bleed. You can have a look there. You can do balloon occlusion also. This is just temporary occlusion of blood flow to the bleeding area. And sometimes we can do stenting and stent graft also in case of a large vessel pseudoaneurysms. So let's discuss few cases. So this is the right colic artery, and from the descending branch of the right colic artery there is contrast extravasation. So to block that vessel that is leading to contrast extravasation, that is the descending branch, have been coiled, and in this angiogram there is no leak of contrast outside. Here this was a case of Whipple surgery. Following which you can see this is the SMA and there is some contrast extravasation just beside it. Following which in that CT angio only there is leak of contrast in the arterial phase. There is leak of contrast into the portal vein. So ideally that should not be there. Portal vein should be opacified in the portal venous phase. So in the arterial phase only there is contrast going to portal phase, that is suggestive of arterioportal fistula. And DSA confirms that this is the SMA, this is the SMA main trunk, and there is contrast going into the portal vein over here. So there is a fistula. So this fistula was initially tried to be closed with a lot of coils. However, still there was persistence of fistula because contrast was going into the portal vein, following which a stent graft was also put. So stent graft with coils led to complete occlusion of that fistula. This is another case here. This is the SMA, this is the middle colic artery, this is the right colic artery, this is the ileocolic artery, and small branches from the iliac artery. This single one branch is leading to contrast extravasation, following which selective cannulation of that vessel was done and coil was deployed over here, and that is showing there is no contrast extravasation now. Now this is a case of 75-year-old male who is having, this is the ileocolic artery, who is having a tuft of vessels that is giving sausage-like appearance, and in fact there is some contrast extravasation into the cecum also. So this is the case of angiodysplasia of colon. This here is the splenic artery, and this is a true aneurysm arising from the splenic artery which is calcified also. So here normally when do we treat this? When the aneurysm is more than 2 centimeter or it's a woman of childbearing age. So this was both, hence treatment was planned. So here a stent was deployed over here, and through the intrices of the stent a microcatheter was passed and that was coiled. So this was a stent assisted coiling. This was a non-covered stent because non-covered stent it's easier to track along these bends, and therefore a non-covered stent was used, and we could have done adjuvant coiling also. This is a case of post-traumatic pseudoaneurysm of the SMA, following which a non-covered stent was put and again microcoils were deployed. So this also was a case of stent assisted coiling. Now what are the risks and complications? There could be rebleeding. However, it occurs very rarely, around 5 to 10% it can happen, depends on the cases. Now if we embolize another vessel or a normal vessel, that can lead to ischemia or infarction of the bowel. Infection is possible and nephropathy can be possible because we use a lot of contrast agent in the angiography. The success rate is usually we have an immediate control of the bleeding and the success rates are 90%. However, there are chances of rebleed. In that time, a repeat embolization might be needed or maybe a surgical intervention might be needed in some cases. Thank you.